Welcome everyone to the Queer See Me podcast. I'm super, super excited. We've already been talking and we were about to I was about to learn all about, I can't even say your last name. Is it Dr. Roden?
Roden, like a small animal without
Roden.
the T.
Perfect.
Yeah.
I was about to ask Dr. Roden, who Dr. Roden is, because we've had so many interactions, but I don't have the full picture. And so I decided we should turn the camera on so I can get that information for all of our listeners.
Oh, hello. I'm Dr. Roden. My name's Claire. I go by Claire whenever I'm not patient facing, and at all other times I go by Dr. Roden in front of patients. I'm an adolescent medicine physician here in the Mid-Atlantic. So what that means is I'm a pediatrician because adults are repulsive, and I only see people between ages 10 and 25. Adolescent medicine is this weird field where literally last week my own brother was like, I don't really understand what you do. What do you do? But we are pediatricians who should have been anthropologists, or anthropologists who accidentally became pediatricians.
Yes.
Or I sometimes like to call myself a pretend-endocrinologist because we do medicine of big emotions, right? So it's a third gynecology, a third endocrinology, and a third psychiatry. So it's a lot of the stuff that impacts you as you go from that kid life to that adult life. How do we make that transition into being a happy, healthy, functioning adult, even if adults are gross? Have you seen their feet? Their feet are so nasty.
Amazing. I don't look at feet anymore because, I only do telehealth and I only do gender care. So when people are about my ex, I'm like, oh, nope.
I do a lot of sexual and reproductive health just kind of globally, which means that I'll do telemed appointments and someone's like, hey, I had this discharge coming out of my genitals. I'm like, you are a minor? This is the internet? No. Please keep your pants on. Yeah. It's I can't diagnose anything with discharge over the phone, and also or over whatever video client we're using. And also it's weird. It's weird,
Yes. I think one of the first things I say, it's not one of the first things I say, it definitely comes up in the orientation visit with my new families of adolescents, is that everyone keeps their clothes on at all times.
Mm-hmm.
That I know I'm a puberty doctor, but no one's gonna take their clothes off on camera. Want to be clear about that.
Oh, absolutely not. No. And even when I see people in person, I tell people I only need to see your private parts in a very limited set of circumstances. And it's mostly if you are having a problem with your private parts. Yes. Otherwise, there's not really you can do your own swabs. People are really good at sticking stuff in their own orifices and don't need me to do it for them.
I had a patient of mine whose PCP refused to write medication necessary for life. This patient, it's a replacement for something that their body is missing. They will die without it. Right. And that PCP said, I won't refill your medication unless we can do a full physical exam, including genitals. And the patient was like, no, I don't want to do that with you. And he was like, okay, then I won't give you a refill. And I was like, are you fucking kidding me? I don't even know what is going on here with you. I was like, would you like me to call your PCP? And the patient was like, no, I just want a new PCP. I was like, okay.
I gotcha. Yeah.
I was a little worried about what I was saying.
So when I was a resident, I trained with some very cool people, in this community hospital in New Jersey. And one of the people who trained me, I remember precepting with him, and I was like, I'm nervous about this thing, so I want to get a bunch of labs. And he was like, Claire, do you want to get labs because they will be clinically meaningful, or do you want to get them because you're nervous? Don't get labs just because you're nervous. That's not nice. It's I've rephrased that a whole lot more activist-y ways, but you can't make anyone do anything. No. That's not how humans work.
No, I know. I think I love oh gosh, we're never gonna get to menstrual suppression. FYI, Claire is supposed to be teaching us about menstrual suppression, which one day we will get to. But I think the word non-compliant to describe a human is one of my pet peeves in medicine. And I feel one of the things I always like to ask when I'm teaching is in the audience, how many of us have taken every medication we've ever been prescribed exactly as directed by our clinician, right? Like, I can't, like, if I've like, you know, when I've had antibiotics 3 times a day, never ever remember the middle of the day, right?
Yeah,
Like, not even like, I'm like, it's just like so hard, right?
And you don't even have to get a hall pass to get out of class to go to the school nurse.
to take it, you know? And so I just like, I think it's like, you know, blaming patients for our lack of insightfulness about being human.
Yeah, it's ridiculous. That's actually, so part of my menstrual suppression counseling is, are you good at pills? Right. And if someone says no, or if they say, I'm great, and their mom's like, oh no, then it's like, tell people like, okay, we should treat the human you are, not the one you think you're supposed to be. So if you know you're going to forget pills and we're doing menstrual suppression, you're going to have bleeding if you forget your pills. So let's not do pills. Let's just do something that isn't pills. You know? Yeah.
Right.
And yeah.
It's like so important. And I think I'm like derailing yet again. I'm like,
it's okay.
It's so interesting because like, right, so many of my trans and gender diverse patients are like so consistent at taking medications, right? Like in ways that like stand out compared to managing other healthcare conditions a lot of times. And that's probably because being trans is not a healthcare condition, it's just an identity. But right. And so I occasionally do have people who really want to be taking their medication and are not capable of doing that. And it's actually a key for me a lot of times to start thinking about like, do you have undiagnosed or unmanaged ADD? Right. Because it is right. Because it's like this executive dysfunction component of like medication management, right? Not that there aren't like a ton of reasons why taking medications are hard that include a lot of systemic oppressive forces. But for people who have the medications, have them in front of them, want to be taking them, are upset that they're not taking them, I'm very much like, have you had an evaluation for ADD or ADHD? Right? Like, just because it's so fascinating. When that comes up. Okay.
And I'll tell parents and kids and adult patients as well, you know, the non-repulsive ones, that like, you probably don't know any doctors who use birth control pills because we can't remember anything. Like, our schedules are crazy. So like, if you can't remember, it's fine.
Not a big deal.
Yeah. Okay. Just be a human.
Okay. Our topic du jour is actually menstrual suppression. And Claire, your pronouns, I don't know that we did that.
Oh yeah, she, her. I'm like, actually her, she, because that's where I live and work.
Fabulous. I love a good pun. Always love a good pun.
I love a bad pun even more.
Yes. And so Claire is going to teach us all about menstrual suppression. And I would love if you would just talk about, like, we're talking to prescribing clinicians typically in this podcast. So I would love if you would just talk about like kind of how you structure your approach to the medications maybe first.
Yeah, sure. So I get a ton of consults for menstrual suppression from cis people and trans people, just a lot of them. And I think a lot of them come from pediatricians or family docs in the community. A lot of them come from parents who are like, hey, if your kid doesn't want to have periods, go see this one. Because some docs are so uncomfortable with the idea of using menstrual suppression in someone who's like right around menarche, for example. So my approach and what I tell patients and what I tell my residents is periods are dumb and you should only have them if you want to. If you want to have them and you cannot, I'm really sorry.
Yeah.
So, but if you want to have periods, carry on. Okay. So with menstrual suppression, that's like, if you don't want to have them, let's talk about the ways that we offer to get rid of them. My counseling, I also usually ask people, you know, there's a lot of confidentiality stuff in adolescent medicine.
Yeah.
So I usually lead my appointments with a new patient with, if it's a minor, there's almost always an adult with them. So I'll tell them like, okay, I'm going to ask you a million questions, and then I'm going to kick out your grown-up, whoever that is, and ask you a million more. And then we'll bring them in at the end, you know, so that there's this expectation of like, you'll get time alone.
Yeah.
I find that sort of springing the kicking out of the parent on people never works. You know, setting it up as an expectation.
Anything on anyone in healthcare never works. It's never a positive experience for anyone. So like,
no.
setting it, Claire like modeling, setting an agenda, which I think most experienced clinicians probably do rely on that technique and tactic, but any new learners or new listeners, like setting an agenda not only helps our schedule, like in our experience with the patient, like be more efficient and more effective. It is also a very important component of trauma-informed care.
Oh,
right?
yes, absolutely.
Expectations of what is going to happen to me, right? Clear, transparent expectations, important part of trauma-informed care. So Claire's modeling that wonderfully for us right now.
I tell my residents, I try to run my practice as if every single one of my patients has a wild amount of trauma that none of them will tell me, right? Because no one has to tell me anything, right? No one's obligated to open their mouth and make sounds. But I am obligated to respect every single person and respect their boundaries and respect their privacy and understand that there are some things that you're just never going to tell me on day one. Like, that's fine. It's like, hi, we met 10 minutes ago. Take off your pants. What? No.
Or so even better, we haven't met at all. Please wear this gown to meet your new doctor.
Hi, there might be some power imbalance here. You also need to be cold. We got really terrible lighting.
Oh my God. So
I mean, I would be laughing if it wasn't truly awful. But like, I try to just like I hate it when schedulers will put something in the schedule that's like history of sexual assault or sexually active or something. Like, as a scheduler, I don't anyone who looks in the medical record can see that. And that's not your information to disclose. So if someone's coming for discharge, just say discharge. Like, that's fine. If someone's coming for gender concerns, just put gender. That's enough. I don't need to know their life story in the 140 characters in the scheduling blurb. Certainly not the most intimate parts of it.
Right. I love, I worked at Kaiser and I'm a patient at Kaiser, right? And so they would always be like, why are you coming up? And I would just say, I just want to check in.
Yeah.
That's all I would say, and then when I got my pre-visit questionnaire or whatever, I put more information in for my clinician. But I don't need the entire team I worked with knowing why I'm coming to see this doctor.
I have a thing on my vulva. Jesus Christ.
Right.
It's like, think for 2 seconds about how would you feel about disclosing this to strangers? Like, not great. Okay, don't make other people do that.
Yeah. Amazing. Okay, so we're setting an agenda. We're setting realistic expectations and transparent expectations with the young person and the adult. We are framing menstrual suppression in the context that it should be accessible to anyone who wants it.
Yeah, absolutely.
And then we're coming up with strategies that are actually accessible for people for menstrual suppression. So whether, that takes into account whether or not taking pills is going to be something that works in their life or not. And so then I feel like we've been talking a lot about counseling. So are there any other tips or tricks you use when you're counseling your patients?
It's mostly counseling. I tell people that I am a medication sommelier, which is to say, if you come in and say, I want a dry white, then I say, cool, here's my list. This is what I got. I do not give you a cider, right? Which when you have a 12-year-old and they're like, what now?
Well, yeah.
I say it's like being a waiter. If you come in and say, I'm really interested in pizza, I'll give you pizza. I'm not going to give you wonton soup because that's not what you asked for, right? So I try in my own practice as much to think about okay, this person's coming to me for thing X. That means that thing X is the point, not whatever I think is the point, know? And if everything is equally safe, then there's no reason to prioritize what I think is best over what the patient thinks is best.
And for any of our listeners who are maybe less well-versed in the world of contraceptive care, I think that the pair that Claire, the point that Claire is getting at right now is actually contraceptive coercion. And this one is very rooted in white supremacy. And two, right, actually was paternalistically, maybe let me rephrase that. It's very paternalistic and white supremacist. I think a lot of the individuals who end up doing contraceptive coercion are actually well-meaning and well-intentioned and just don't realize that it is harmful.
Yeah.
Because what's the governing body that made the recommendation for LARCs? Like LARC first.
There was a whole bunch of them. So ACOG made the first set of recommendations. AP and SAM also followed suit. SAM is Society for Adolescent Health and Medicine. And I think North American Society for Pediatric and Adolescent Gynecology did as well. And over time, they've kind of tempered their recommendations to be, their recommendation was effectiveness-based counseling, that like you present your options in order of effectiveness. And over time, that's been sort of tempered to in a patient who has no particular priorities.
Yeah.
Yeah.
Great.
Yeah. Yeah. And in a patient who otherwise has particular priorities, it's shared decision making.
Great. So. Yeah. And so if you've ever heard that concept, clinicians, of LARC first, that is actually like what we consider contraceptive coercion. It's like, it's prioritizing our values as a clinician over our patient's values.
Yeah.
And that's wrong because it's about their body, not our body.
Yeah. I tell my patients and I tell all my trainees the best birth control is the one you're going to use. Like,
right.
It's very simple.
The one you were interested in, the one you wanted. And that doesn't mean like everyone comes to us knowing what they want or everyone comes to us like having this information, but it's absolutely like slightly back into the world of gender. This is gender affirming care, but like slightly back into the world of hormone prescribing for gender affirmation. Not that this is whatever, you know what I mean? But
you only get the one human body and yet it has so many needs.
Yes. Right. And so we very specifically ask our patients during their intake process, are there any treatment options you're particularly interested in? It's it's on our paperwork. They've already written it in for us before we see them. So we know up front, like, oh, I haven't really looked into anything, whatever you recommend, or I've read everything that ever existed on Reddit in trans feminine science. And I went cyprotarian and estrogen and spironolactone and, and so we can talk about that. And so I think it's just like, it's so important, this point that Claire is getting at. So, okay, you're the sommelier, which is a hard word for me to say. I think I pronounced it correctly.
You did a beautiful job. And I start my gender appointments with like, hi, what's your goal for this appointment? And then what is your family's goal for this appointment? Like, because if you're coming in and you say, I would like a referral to a surgeon, that's a really different appointment from someone who's like, I need to stop bleeding all over the place so I can talk to my therapist. Like, those are different appointments.
Yes. Yeah. Absolutely, like patient-centered, goal-driven, individualized care. Okay, so you're centering your sommelier analogy, and then what happens next? What's your next counseling with your patient?
So then my next counseling it's exactly what you do. It's is there anything you're particularly interested in? Do you, or if they're like, look at me like, so let's pretend that I'm talking to an 11-year-old, right? And the gender is actually irrelevant. Kind of is, because if you're doing patient-centered care, you are centering this human in front of you and what their priorities are. So let's say that we're talking with an 11-year-old, which for the sake of argument, we're going to use they, them pronouns for the sake of this little example, because gender is irrelevant. So let's say that you say this person's coming to see you and they need their periods to go away for whatever reason. And at 11, I might not kick the parents out for very long, or I might say, 11-year-old, like, do you want your parent to stay in the room with you? And a lot of the time they're going to be like, they have no concept of the kinds of questions that you might even ask them. So they'll say yes. So then with the parent in the room or without them, talk about like, okay, so what do you want to get out of getting rid of your periods? Like, how do you want to do it? What matters the most to you? Do you want something that you do every day or something that you don't do every day? Do you want something that gives you pregnancy prevention or something that doesn't give you pregnancy prevention? Or it might, but we don't really know. Do you want something that's really effective for periods? Something that's really effective for pain? And the bleeding doesn't bother you so much, but like the physical pain does. So it's what matters the most to you? And then you go from there. And so for older folk, in my state, the confidentiality laws kick in at 14. So certainly at 14 and over, I'll talk with people alone about like, okay, do you need contraception in addition to menstrual suppression? And then, do you need your mom to know? Like, do you need your dad to know that that's what you're here for? Or do you need me to not tell them? Because if you don't want me to tell them, I am legally obligated not to.
Yeah.
But I
Yeah.
can steer the conversation in whatever way we need to in order to get your needs met.
Yes.
Yeah.
And I think Claire is, bringing up really great points. Clinician consent for I think most clinicians know this, consent for sexual reproductive health care. It varies by age in every state. Every state has a different piece of law around it. So know your own states. I also, when I work with adolescents, like very transparently tell everyone in the room before I kick the parents out, what I will tell people and what I won't. Right. So like, right, everything you tell me in our time alone together will stay between us unless you tell me you're thinking about hurting yourself or someone else, like within the next 24 hours, and you actually have the means to do that. Or you tell me someone is hurting you.
Yeah.
Right. And very specifically in the world of like sexual and reproductive health, like the component of
I love your dog.
Thank you. He like almost fell out of my lap. I'm like, what's the word for when statutory? Statutory rate, right? And so navigating that intersection with adolescents. And so being really clear and transparent about like what I am like quote unquote mandatorily required to report. I do think mandatory reporting makes us agents of the states and is very specifically targeting Black families to take their children away from them. So
it's I feel so complicated about it. Right. I mean, in some ways I don't feel complicated at all. And in other ways I don't feel complicated at all. But those ways in which I don't feel complicated are at odds with each other, which is the complicated part. So I'm pausing. I forgot what I was saying.
Yeah. I just like to be really transparent about like what is mandatorily required of me to report, so that people know that before they say things to me.
Yeah.
Right.
I tell kids that everything we talk about between us is just between us and like the medical record. I tell them I use a type of documentation. If your parents are looking in the chart, if they're that kind of parent, they're not going to see what I write. So, and that I can't tell them the stuff we talk about unless I'm worried you're going to hurt yourself. I'm worried you're going to hurt someone else. Someone else is hurting you. Or we discuss that for some reason, like you want your parents to know.
Yes. Right. You could give me consent. Yeah.
And then, and that like most of the stuff that I talk about with kids without their parents is like not that interesting to parents. It's like they don't actually want to know what kind of sex their child has. I am a parent, and when I think about my kid when she's, old enough to be interested in sex, right now she's 6, she's like very prepubertal. But when I think about her as, let's say, a 16-year-old, it's like, honestly, I don't want to know. I just want to know that whoever she's doing that stuff with is like a good human. Like,
yeah. Right. I think, like that transparency around what remains, confidential and what doesn't is a super important part of working with adolescents. And then I think, right, what goes in the medical record is we could have a whole podcast about that. We're not gonna go into that today because we're gonna stick on menstrual suppression. But maybe that will be a topic we discuss one day. Our practice like recently discussed like coming up with like a code sheet. Right. Just because our field is getting that.
Yeah, it's complicated.
Complicated.
And my complicated feelings. So my bestie here, so I'm in the cornfields in Hershey, Pennsylvania. My bestie out here is a family planning physician. So she's the medical director of Planned Parenthood Keystone, which is 8 Planned Parenthood clinics. And she also does care in my hospital system. And our kids are 2 months apart. So the children are besties. So we are besties, but it actually happened the other way around. It was mom's first. It was like, here is your mandatory best friend. So she is literally radical. Like, I am a huge fan. But one of the things that she and I talk about is how different our documentation has to be, because hers is minimum necessary. Like this person is coming in with a pregnancy loss, the end. And mine is this person meets diagnostic criteria, blah, 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 blah. Because in Pennsylvania, we have a mandate to cover gender affirming care as medically necessary. So I have to prove that it's there.
Right.
Which is so different.
It's right. And it's like, there's all these different strategies and approaches, and we should do that podcast another day. I'm going to get us back to menstrual suppression. Okay. So we're focused on the medication that like someone's interested in. So if they have no preceding interest, right?
What do I do?
Yes. Yeah. And obviously you talked about focusing on their goal. If they don't have an interest, you focus on their goal. But let's say we're just focusing on just stopping periods, stopping the bleeding. There's not a significant amount of pain. Pregnancy prevention's like not necessary, but it's fine if it's there.
Yeah. So if I'm talking to someone, let's say that we're talking to a 15-year-old by themselves, and we've kind of gotten to this point of like, okay, what's your priorities? Because I'll discuss it with the child first alone. And then I'll say like, hey, do you want me to bring your adult back in to help with decision making? Because a lot of times people are like, yes, I need my mom. I need my mom for this decision because I've never had to make a decision by myself because I'm 15. Yeah. Or they'll be like, absolutely not. No, we will make a decision and then we will make my mom make the same decision. It's like, okay, fine, whatever you want. So if the parent comes back, they come back. That's fine. I kind of wish every child could have their parent come back in to help them with decisions. There's sort of this idea that adolescent medicine doctors are like, parents are evil, get rid of them. When like, no, I want every young person to have a home that loves them and supports their autonomy and their decision making in an age appropriate way. Yeah. So then we talk about, okay, within the family culture, if you don't have any particular priorities, does it matter if something's contraceptive? Like, are you going to be able to sleep at night if something also provides contraception? And if the answer is yes, then we talk about more options. And I'll usually say up front, if there's a gender component that we've been talking about as well, that I don't love prescribing estrogen unless there's a specific reason to. So I try to avoid contraceptive estrogens in people who don't specifically need them, which can, like, the specifically needing them can be, doctor, I would like to be on an estrogen containing birth control pill. Like, that's fine. Yeah. I don't care. But the estrogen component is what conveys all the medical risks. So unless you want something like a conventional birth control pill, patch, or ring, like, we don't necessarily even have to think about those. Yeah.
I just like, I don't know if you've seen this. I feel like moderate to higher dose combined OCPs like do actually seem to slow down changes from testosterone therapy.
They do. And I find the patches do as well.
Yeah.
Yeah. Because they are like higher estrogen exposure. And my like being kind of wishy-washy on the pill changed the course of human history, right? Like, it's amazing. Yeah.
Equal
is like, that is the part that has all the like blood clot med interactions. It's like, if you don't need this, let's not do it, because that part is the risky part, the medically risky part. So then we talk about that. And if someone's like, I want to be on the pill because my friends are on the pill and it is discreet within my community, okay, fine, whatever you like. Yeah. So then I'll say, like, if you don't have any particular priorities, then I'll be transparent and say, like, I'll go through them in order of contraceptive effectiveness or what we can start today versus what we can't. Because if I'm seeing someone on telemed, like, I can't give you an IUD on telemed.
Yeah.
So I can't start that today, but I can start norethindrone acetate today. So you could just send that to your pharmacy, right?
Yeah.
So I'll offer, usually say, we're not going to do any estrogen containing things unless that's what you want, which is a different conversation. My general go-tos are going to be norethindrone acetate. The brand name is Agestin, which I have a lot of good luck with. I like that one. Who was that? Oh, sorry. I'm also on service, so I have to make sure that when my phone bloops, it's not someone terrible, something, I love norethindrone acetate, 5 milligrams. Works very nicely. Good bone health profile, wonderful.
Great.
I use a lot of danazol, usually at 200 milligrams twice a day. So I'll tell people, like, danazol is a very effective menstrual suppressant that can behave a little bit like testosterone light. Like, you'll get maybe some pigmented hairs. You might sound a little hoarse. Your chest might be a little bit less full, maybe, I don't know. You might get some zits. You will probably gain weight, but it's twice a day, and it's not forgiving about twice a day. So you will bleed if you forget your doses. Yeah. And then if you need contraception, there's also, or you're bad at remembering pills, which is fine. Depo-Provera, once every 3-month contraceptive injection, which if you like it and it's working for you, you can do it at home. Like, you don't need to come in and see me to do your shots. And then like the thing that I know to be most effective for bleeding suppression in the long run that also provides contraception is a 52 milligram levonorgestrel IUD. So a Mirena or a Liletta. And certainly since I see a lot of kids, they're often like, absolutely not, like you say, uterine, and they're like, blah. So then I've like, if you make that face, we're not going to keep talking about it. It's fine. Like, I don't, whatever. But if they want to talk about it, my institution does offer IUD placement with sedation, which is in collaboration with that family planning group. My bestie, I love them. Yeah. And usually we can get pretty decent insurance coverage if you do the documentation appropriately. So where I practice, it's if you have a history of sexual trauma, you don't have to tell me all about it. It can be a yes or no question, right?
Yeah.
Anxiety on medication, history of autism, or you tried to do a pelvic exam and it was a mess. Like the person hated it. Then you can get it under sedation.
Yeah.
So I'll tell people, like, if you know you're going to need it under sedation, that's fine. Like, we'll arrange it. Sedation carries risk as well.
Yeah.
If you want me to do the placement, I'm happy to do it. If you want to prioritize getting it as quick as possible, I'll send you to family planning, and they're going to be just as interested in your autonomy as I am.
Yeah.
It's up to you.
Yeah.
So that's, but I can't usually do it same day, mostly because of the way my clinics are set up, which is annoying.
And also notice, Dr. Roden did not mention Nexplanon.
Not. So also, full disclosure, I am a Nexplanon trainer for Organon Incorporated. I haven't actually done a training in like 18 months or something, so I might stop because the disclosure part's getting annoying. But yeah, the arm implant is really fantastic contraception and fantastic pain control, but it is not great for bleeding. If someone comes to me and they're like dead set on it, then I'll say, like, of course I will do whatever you want. I don't think this is harmful as long as you are okay with this risk, and if you're okay with this risk, it's not up to me to decide what risks are acceptable to you. So, yeah.
Yeah, absolutely. Okay. I love this. We have like some framework for counseling. We have some framework for medication. I have like a challenging question. And I do have a hard stop in 7 minutes, so we'll have to be quick.
Sorry. Yeah.
But my like challenging question, and I don't know how much this comes up in your practice, so if it's not appropriate, that's rad. But like, what is your approach to someone who has not had menstrual suppression successfully on testosterone therapy alone? Because I see this question come up a lot in like
does someone need to be on menstrual suppression to be on testosterone?
No. So someone's on testosterone therapy for gender affirming care, for trans health care. And we're like 6-9 months in, and their periods haven't stopped on their testosterone alone, and their dose is in like an appropriate range, and their levels are in an appropriate range, and we're still not getting menstrual cessation. Like, what would you think about trying next?
Oh, so again, this is going to be in people under 25, which I think is an important caveat, because if you're 40 and on menstrual suppression and you're having anovulatory bleeding or what have you, that's a different ball of wax than if you're 15. So it's basically the same thing. I'll offer people basically the same thing. I might be less interested in offering Depo, but that's for no particular reason.
Yeah, I'll say Depo is the one I reach for most often. Actually.
Oh, okay. Yeah.
I never used it much in cis kids when I still did primary care.
Mm-hmm.
It was on my counseling, my list of counseling, but like, I think I was always a little bit more reserved about like bone mineral density and like,
I can talk about that. I can talk about bones. Yes.
Well, but when I'm giving people testosterone, I'm a little bit less worried about their bone mineral density, because testosterone is like pretty fabulous at building healthy bones.
That's one of its many jobs.
Yes. And so I'm a little less concerned about that. And then I think the like only having to do it once every 3 months, right? The like not having to take a pill every day, that it's not going to impede the testosterone effects in the same way that combined OCP2 does. Like I tend to reach for it a little more often. I also, on the table for that have, I also think about raloxifene and anastrozole.
Oh, cool.
And
I use those very rarely, but it's patient population.
yeah, different patient population. What's the generic for Alyssa? What's the medication name?
Is that one of the
GnRH.
Is it the nosy spray ones?
No, that's Nafrelin or Synrelin. Nafrelin is the generic for that.
Yeah.
Or Alyssa is a pill. It's
Allegalloa. Yes, I know what you mean. I getting insurance coverage for those for like not endometriosis is a bear.
Yeah.
And like getting insurance coverage for norethindrone acetate is easy peasy lemon squeezy. And we
Right.
also have this new over-the-counter oral contraceptive pill, which is sort of this like dark horse. Who knows what it's going to do for bleeding, but I really hope it's fine because like ultimately the patient knows what they need. And if they need to not have a period, they don't necessarily need to see me because taking a medicine to get rid of your period is fine. Like, who cares? So I'm very curious to see how that changes the game.
Ooh, that would be so interesting to hear.
Yeah. And then I will say, because I know we have a hard stop, but I will say that one of the questions I get the most from healthcare providers is lower age limit. Yeah. And the lower age limit is menarche. It is not a calendar age. Right.
Yeah.
So for my patients, especially like, let's say that I'm seeing someone who is suicidal whenever they have their periods. Yeah. Right. Yep. Saying like, oh, I'm worried about your long-term bone density when you will be dead.
Yes.
Like, does not matter. Or like someone with a bleeding disorder, right? Like if I'm exposing you to blood products once a month over the course of your life, that is not benign. So there's no, and like, I think it's also worth remembering that like the first person diagnosed with von Willebrand disease was someone who died at menarche of a hemorrhage. Like this can be like very, very dangerous time. So I do request that people have had some bleeding before starting suppression because like, we don't know that your plumbing is intact until you've had bleeding.
Yeah.
Like we don't know if you have a uterus, it is not established until you've had some bleeding. And you might not have one. That happens. So
yeah, or it might not be connected in all the ways. And that's like, right, that's like a slightly different part of gender affirming care, right, where we don't actually necessarily get to menarche before we start puberty blockers.
For puberty blockers, that's a different ball of wax. Like
totally different.
Like ideally you would be able to start like if you're getting to menarche, then you're kind of late. You know? Yeah. That's the last thing.
They are effective at stopping periods.
Oh, they're great for it. They're very effective.
Yeah,
I worry about bones in the context of someone who doesn't specifically need pubertal blockade.
Yeah.
Also, insurances in my region are like a mess.
Yes, they're very expensive, right?
Yeah.
Oh my gosh, I feel like I could talk to you for like another hour. This has been so much fun. Thank you for sharing like your counseling tips and tricks and like how you approach things. I feel like those kind of strategies are always so helpful for listeners to hear.
Yay, thank you. Well, should I give my email perhaps?
If you are interested in sharing that with we have like 3,000 listeners.
So. Oh my God, maybe not because I'm too shy, which is weird to say. But my legal name is Rosemary Claire Roden. Rosemary spelled like the plant, and Roden spelled like a small animal without the T. And I am the corresponding author on a whole bunch of academic papers. So that's how you can find my email.
Yes. You're pretty are you on the GHC listserv?
Yeah. I'll talk to a telephone poll. So like So like I'll definitely talk to people on the listserv.
I was say, Claire, you answer quite a few questions on the listserv. You're fairly active there. And so if y'all ever have questions about this is a boundary I have, which I've never said on the podcast, so great for people to hear this, is if you have questions for me and you do not pay me. So if you are not a member of the Queer See Me platform, I just ask that you actually post them on the listserv because that allows me to like respond when I have time and allow the work to be shared by other rad clinicians like Dr. Roden and you know, all the other clinicians that contribute over there.
It is such a wealth of information. I love it so much.
It's so good. It's so good.
Yeah.
And if you're not on the listserv and you want to be on the listserv, you can reach out to me and I can sit down and have a chat with you and make sure you're appropriate for it. Rad.
Yeah.
Okay. Thank you so much for your time. It's been nice to see your actual face.